Good afternoon, everyone. I am Dr. Shehzad Safdar, and I am here to present a study that was conducted in Punjab Institute of Neurosciences, Lahore, under kind supervision of Dr. Muhammad Anwar Chaudhary. Now, the title of presentation perfectly explains our objective. That was to establish the role of ETV as a comparable alternative to VP shunt in obstructive hydrocephalus secondary to infratentorial tumors. A lot of studies have already been performed regarding that topic, but most of them only included the pediatric population. First, a quick literature review. A meta-analysis of 8 cohort studies were published in 2015 with a total of 652 patients. And they concluded that therapeutic equivalence was same for ETV as well as for VPS. But ETV was preferable in terms of lower surgical time, lower incidence of post-op complications, and lower rates of reoperation for hydrocephalus. A second meta-analysis was published in 2018 with a total of 2017 patients. And the conclusion was kind of same, that ETV has greater benefits in terms of lower major complications, lower rates of infections, lower rates of reoperation, shorter duration of surgery, and shorter hospital stay. Now, shunt dependence. About 70 to 90% of infratentorial tumors present with hydrocephalus, out of which 85% are treated before tumor excision. However, just 20 to 30% of patients with hydrocephalus secondary to infratentorial tumors need a permanent CSF diversion. This concludes that about 65 to 76% of VP shunts can be rendered unnecessary after tumor has been excised. Now, this is quite an alarming figure because this indicates that patients who had hydrocephalus and infratentorial tumors, they had their tumor excised, they had got their radiotherapy, but still 65 to 76% of those patients are living with the shunt under their skin, in their brain, and in their abdomen. So this is basically the numerical agenda of our study to reduce the number below 65%. Shunt failure. Shunt has been a very commonly and extensively used procedure in neurosurgery. It has been a life-saving procedure in emergency setting and a life quality improving procedure during elective surgeries. But it has an inherent shortcoming. It involves a placement of about 100 centimeters of foreign body hardware under your skin. So as long as the hardware is there, it is always prone to failure in terms of infection or blockage. So the average rate of shunt failure within 1 year is about 27 to 30%. ETV has its own complications, but they are fewer as compared to VP shunt. The cumulative complication rate is about 5 to 15%, mortality less than 1%, permanent morbidity just 2.1%, and an overall success rate of about 90%. And these are the two benefits that nobody can debate about, nobody can refuse, and nobody can deny. This is the superiority of ETV over VP shunt, that in ETV, you do not need to place a permanent hardware in the body. And second, there are virtually no abdominal complications related to ETV. Now coming to the main study, it was a prospective descriptive case series. The sampling technique was consecutive non-probability. The duration was 6 months, but the patients were recruited only during the first 3 months. The demographic details were documented. Diagnosis, symptomatology, neurology, and radiology were the three things on which we compared the patients pre and post operatively. Mean follow period was 3 months. And we also documented the pre-op KPS and ETV success score. Exclusion criteria was the patient younger than 10 years were excluded, as well as the patient whose KPS score at presentation was less than 70% because they were dealt in emergency by VP shunt. Post-operative, the patients were kept in ICU for 24 hours, and again, improvement in symptoms, neurology, and radiology was documented and compared with pre-operative status to analyze the results. 3 scans were obtained, first within 24 hours after surgery, second after 2 weeks, and the third one after 3 months. Now, this is a case of a 14-year-old girl who presented with infratentorial tumor and hydrocephalus. These are the pre-op MRI, and ETV was performed and tumor was excised during the same sitting. First we performed the ETV and then we excised the tumor. And here is the post-op scan. You can see that the tumor has been excised and there is no new complication or any new finding in the post-operative scan. The total number of patients was 20 with the mean age range of 28 years and the duration of surgery was just 18 minutes. Now this shows the result. Basically, we had just used 5 symptoms to compare, including headache, nausea, vomiting, gait disturbance, seizures, and incontinence. And the radiology was compared after first week and at the end of 3 months. Now this shows the improvement in symptomatology, where headache was improved for up to 90%, nausea, vomiting for 75%, gait disturbance in 50% of patients, and incontinence in 67%. However, the seizures were controlled in all of the patients who presented with fits preoperatively. Radiological changes improved in about 83% of patients at the end of 3 months. Out of these 20 patients, no intraoperative or post-operative complication was documented. And even if we had documented any complication, we would still prefer to perform ETV as long as the complication rate of our ETV remains comparable to that of VP shunt. Now concluding the discussion is that ETV is quicker and safer method for CSF obstruction, diversion in obstructive hydrocephalus, and after a successful ETV, most of the patients do not need the placement of VP shunt hardware. So they are prevented from cranial, abdominal, or any other cavitary complication. Recommendation: a patient who is suffering from infratentorial tumor and hydrocephalus will have to undergo tumor excision surgery, then radiotherapy. So there is a brief window of relief that we can provide via ETV. This will alleviate the need of placement of a permanent VP shunt. So in my opinion, any patient who is a candidate for ETV deserves a chance to live a shunt-free life. Thank you.